Hello and welcome to another Rural Doctors program. I'm Jerry Gannon. Thanks for your company once again. Tonight our program will focus on some issues in orthopaedics. Along with our normal discussion, we'll take some time tonight to talk through rotator cuff injuries, and later we'll hear from Professor Alan Bryant, head of the podiatry program at UWA, about the use of orthotics. But first up, let's meet our guest. Dr. Olga Ward is back with us to guide us through the discussion. Welcome back, Olga.
Thanks, Jerry.
And joining Olga to discuss your questions and ours is firstly orthopaedic surgeon Dr. Jonathon Spencer. Welcome, Jonathan.
Hi, Jerry.
And our second orthopaedic surgeon is Dr. Colin Whitewood. Welcome along, Colin. Nice to have you back again. It's been some time since you last joined us here.
Yeah, looking forward to another good discussion.
And I think your visit back is timely because neither Olga or I are getting any younger, and both of us will shortly start to suffer from creaking bones. Isn't that right, Olga?
Well, speak for yourself, Jerry. I'd say one of the most common presentations to the GP is, in fact, widespread chronic joint pain and stiffness. I guess it's usually associated with osteoarthritis and sometimes just with muscle tension, but is there anything that really rings alarm bells for either of you?
Well, I mean, in the elderly population, you've always got to keep in mind a couple of endocrine type issues. Once you get past 70 years of age, your rate of primary hyperparathyroidism from a functioning parathyroid adenoma go through the roof, so checking a calcium level is warranted, because you remember the moans, groans,
Stones and bones, yes.
And bones, exactly. So looking at someone with generalised bony ache who are elderly, don't forget to check that sort of thing, because you can look stupid if you don't. But yeah, a lot of the even middle-aged adult population now have been thrashing their body and are expecting to still be as good as teenagers. And we're seeing a lot of premature osteoarthritis in people who don't accept the fact that they're getting older.
So this is people who just run too many marathons or go to the gym too often? When you say thrashing their body?
Well, I think there's just a high expectation to live a very high quality of life right up until the day you die, pretty much now.
Yep.
And so people are playing sport, going for long walks, doing all the sort of activities that they want to do to give themselves a good quality of life.
Which we've been encouraged to do, John, by medical professionals and public health campaigns and what have you.
And absolutely, and I think and those sort of things are probably good for your cardiovascular system, your weight and all those sort of things, which is in general good for you, but your joints do wear out with repetitive use. So ultimately, the more force and repetitive trauma your joint goes through your joint, the more likely it is to wear out at an earlier stage.
I mean, the media now shows the guys on the footy field, the guys on the rugby field, coming out doing all these wonderful moves on the rugby field. But what you don't see is that a lot of the Eastern States rugby sides at half-time have rows of syringes on the tables, and the guys just come here saying, I'm sore here, and they just stab them with local anaesthetic so they can get through the second half. Now, pain is supposed to be something that protects you from injury. The fact that these guys are trying to ignore their pain is probably the reason why they end up as finishing their career in their 30s or 40s with joints that look like 70 and 80-year-olds.
And that's reflected in the general population, obviously at a lower level, but everyone still wants to lead a life like that.
We've got a serious problem here. Well, so one half is obese and the other half is their bodies are breaking down because they're putting in too much of an effort. But what about preparation, though? What should GPs be telling, footy clubs and cricket clubs all over the state? GPs play a very important role in public health messages. Are there anything they can should be telling people, young people in particular, about how to look after themselves so they don't end up like this?
Well, one is realistic expectations. Not everyone's a world-class athlete or can be a world-class athlete. The other thing is that your level of physical exercise shouldn't be a seasonal thing. You shouldn't sit there all winter getting chubby and then the week before the first game of the footy season suddenly decide to go out and run 10Ks. It's not going to work and it's going to trash your joints. So if anything, you should slowly change your lifelong exercise patterns rather than do it seasonally.
So no off-season, basically?
Well, yeah. Or two
Just
seasons.
get in the swimming pool in the summer.
Yeah, have a
Keep
winter and a
the
summer
fitness
season.
Well, it's just managing everything in moderation, isn't it? Which is the sort of generalised doctor's advice, isn't it? So, but it's the problem is it's difficult for people to actually do that, because as we come into a more specialised world, people are working hard. They're painters and decorators and builders, and they're under pressure to do their jobs by certain time and keep fit. So they're actually putting themselves through an awful lot of physical abuse, which the results of which we're seeing.
The other thing I see is a lot of patients who are very significantly overweight and whose joints are just simply carrying too much. And of course then they say to me, well, I'm trying very hard to exercise, but it hurts so much to exercise. Do you have any specific advice for them?
Yeah, they need to go on a structured weight loss program, and of course they need to lose weight, and that's good for them in every aspect of their health, not just their joints, their diabetes, their heart disease, their mental well-being, and so that is a priority, and it is very difficult for someone who's got painful arthritic joints, who's overweight, to exercise it off. This is my opinion anyway. I mean, it needs to be
A balance between diet and exercise.
what goes into their mouth just needs to be drastically cut.
But what are the kind of things that can happen to obese people, Olga? What are doctors seeing in their surgery in terms of the damage they're doing to bones and skeletons?
I think most of the damage is just the regular wear and tear. What you do see is that people who are obese take a very long time to actually recover from any injury, and if they have a fall, it's more severe because of the extra force that's involved. And usually more complicated, and they tend to get more bruising. So everything's just kind of shifted a little bit to the more
High
complicated.
blood pressure, you've got the impaired glucose tolerance, the type 2 diabetes, the difficulty breathing, the snoring, the obstructive sleep apnea. There's a huge liturgy of things that go along with the being overweight and obese.
Yeah.
And by the time they start complaining about their sore knees, it's usually because they are worn out. They've reached the end of time. So to do something about it then is very difficult because they can't exercise it off.
Because the knee is only designed to carry a certain amount of weight, which is the normal average weight of a person. Now, speaking about knees, and going back to our early topic about young athletes thrashing themselves, why is it that we're seeing so many people doing their knees, blowing out their knees, anterior cruciate ligaments, and we find out so much about this on television from finding out what's happening to our heroic athletes?
I have suspicions about country netball myself and meniscal tears.
Well, one of the very well-known orthopaedic surgeons in the eastern states tried for many years to get the netball rules changed to add an extra step in because it would decrease the rate of ACL injuries, but of course failed. You
mean 4 steps instead of 3 before you have to change the ball, before you have to throw the ball?
After you land. After you land, you're allowed to take 1 step.
Oh, righto.
He was trying to bring in after you land with the ball, you were allowed 2 steps, just so you weren't trying to suddenly stop your entire body weight on one knee, held together with one little bit of gaffer tape called an ACL. You overload the structural integrity of the ligament and it just fails. But he failed to get that through because netball is netball and nothing was ever going to change that. We're seeing more because people are probably pushing harder at their sports. People want to achieve the level that a very few select people get to. They're watching these people at international competitions any day of the week on TV, and every parent wants their child to do that, so they're into the special clubs, they're doing sport at school, sport after school, they're in the state development squad for this, they've got their special coach.
There's almost like a sense of failure if you're not an elite athlete at a certain aspect of things.
That's right. You aspire to doing what the West Coast Eagles are doing, and Geelong and these other teams. But all of those teams have got massive medical assets at their disposal. Why aren't those doctors who work with football teams doing the right thing by the athletes in terms of preventing these injuries?
Great question. The footy players are only now just starting to look back and start to sue their football clubs for the damage they've suffered. It's unfair in some respects because the footy players have tried to stay on the field at all costs, and the doctors have tried to help them do that without causing them too much harm. But I mean, every time they have an injection of steroid in their joints, it's now been clearly shown that steroids destroy chondrocytes and cause chondrocyte death through apoptosis. So if you have to have a steroid injection to get through because you've got such crappy disease like rheumatoid arthritis, that's reasonable. But if you've hurt your joint and it's going to get better if you wait 2 weeks, then you're probably better off to wait the 2 weeks than have a steroid injection to see if you can get back on the field in a week.
Now, country footy is every bit as competitive as the AFL. Am I right, Olga?
Country footy, country netball, country hockey.
Exactly.
Well and truly.
And I guess because there's a shortage of real numbers to make up teams in the bush, there are people who are playing football, netball and hockey, getting places on teams who are physically not good enough. In other words, if there were more people around, they probably wouldn't be getting a posse. Am I right?
I think people tend to play a lot longer, as into a much higher age than they would in the city.
Because there's a shortage of numbers.
Partly because there's a shortage of
There's
numbers,
the
and partly
social,
because it's the
you know,
it's a
it's
big
the main thing.
social
That's
event
right.
of the week.
That's right. But there's a lot of pressure. What you're saying is that these people need to realise their limitations, which is what you were saying, Colin.
Yeah, but also you've got to remember these are choices that people are making. The reason the football player is playing is because he's earning money. It's his career. It's how he's, making his place in society at this time, and that's how the country football players they enjoy it. It's the social structure of their life at that time, and it's hard. These are choices they're making. So as the doctor, you just can't say you can't do this and can't do that. This is
just be aware of the consequences.
Yeah, exactly.
So, Olga, what else are people coming through our country GP surgeries with when it comes to orthopaedics?
Well, like I said, I think osteoarthritis is certainly the biggest thing that we see. And I guess we're all looking for a magic bullet. What's your magic formula for treating osteoarthritic patients?
Well, I mean, the first thing I do, is to try and, you need to educate the people as to what's actually wrong with them, why it's happening, what are the factors which we've all discussed, are the things that contribute to this condition, and then try and explain to people what's likely to happen to them in the future if they don't change certain aspects of their life, whether it's their weight, whether it's their sport, whether it's their expectations. And I think that's the most important thing, because this is a disease you can't cure, you can only manage, so to speak. And the patient actually needs to learn to manage that condition themselves. Other than that, I mean, yes, we use the variety of drugs and glucosamines and physiotherapy and exercise regimes that are well known.
Yeah.
And I don't think there is a magic bullet.
No, well, Jerry and I were talking about glucosamine and chondroitin earlier. Is there any evidence that it works? And how does it work? Or what does it work on?
Well, I mean, my opinion is that and I think the evidence shows that the glucosamine and chondroitin do improve the symptoms of the patient, and they certainly improve them to the point, improve pain, equally as efficaciously as non-steroidal anti-inflammatories without the side effects of non-steroidal anti-inflammatories. But what I don't think they do is replace the cartilage as it says it does on the package, so to speak.
So is it just preventing cartilage loss then, or slowing it down?
It may be slowing it down. The mechanism of the analgesic effects is not understood. John was talking about patient education, and I think the hardest thing to do is to teach people that the layer of articular cartilage they've got when they're kids has got no blood supply, and when they reach skeletal maturity, they've got no healing potential. So it's a bit like the tread on a tyre. As it wears out, it's gone and it's never coming back. So by the time they've got severe thinning of their chondral surface, they've got very limited life expectancy of their joint left.
So where is the research heading? What is the research looking for in this area?
We've got some breakthroughs with Macy grafts, which have been in the press a lot in the last 5 years, taking a little bit of cartilage out of someone's knee, ankle, shoulder, whatever, crushing it up and getting the chondrocytes out, growing them up in a lab until you've got millions of chondrocytes, putting them into a porcine membrane and then implanting them back into a joint. But that only works when you've got a well-contained defect, and it's a bit like having a hole in a plaster on a wall. If you've got one chunk of plaster that's fallen off, but it's got a nice surrounding area, most people can bog that up to look okay. That's where we are with these sort of grafts in joints.
Right, so a Macy graft is a SPAC filler.
But
if you need to actually plaster the whole thing, it's
we
gone.
can't do that. That's gone, and that's where the joint replacements come into them.
But what can patients do in terms of not allowing this to happen to them? In other words, preventing the loss of cartilage?
Well, I mean, some people have a genetic predisposition for these things to happen to them much, much earlier on in their lives.
So design, fault, blame your parents.
Exactly. So there's nothing they can do about that. Some people have fantastic cartilage that lasts the rest of their life, the whole life, and other people it wears out very, very quickly. The only thing they can do is alter the environmental factors i.e. the mechanical forces that go through it. So reducing the weight and modifying the type of exercise and the way they live their lives to help it last as long as possible.
But normally people wouldn't expect to be suffering these sort of things until they're well into their 60s or possibly their 70s. But are you not seeing people at much younger age with these kind of conditions? So
people who have a genetic, who have a genetic sway towards having poor quality cartilage and put huge amounts of mechanical stress on it, etc., will wear out at a much earlier age than previously. And these are, diseases of degeneration, and we now live a lot longer, living much more active life. So diseases of degeneration are much more prevalent than they were years ago.
Now, Colin was talking earlier about intra-articular steroids and chondral death and how they're not really all that efficacious except for settling down acute inflammation in inflammatory arthritis. There used to be some stuff on the market called Synvisc, which seems to have evaporated or died a natural death. Was it any good, and was the principle any good?
The studies were interesting, injecting back hyaluronic acid into a joint because, again, it seemed to have some pain-relieving aspects, which were good. The idea that it gave increased lubrication to a joint sounded very good. There were some early studies done that compared it to injecting normal saline in a randomised, blinded, controlled manner, and they found that there was no difference.
So
This
very
got the company
disappointing.
very upset. The company has then gone on to sponsor another study which they're paid for, which has shown a difference, but it's not too big a difference to just sticking someone with a needle. A bit like acupuncture, if you stick a needle in someone, it's a very, very powerful placebo, and they feel better, even if you put it in a different spot.
Just before we get off this topic about glucosamine, chondroitin, what about fish oil? Is there any evidence to suggest that fish oil helps?
There is some evidence, but it's poor evidence, a lot of anecdotal evidence. There's some purported mechanisms which you can work through, but then again, it's also got the added benefits of the effects on the brain, the effects on the heart.
That's right, yeah.
So, I mean, if people feel better on it, then I tell them to get tried.
But it ain't no silver bullet.
No.
Okay, all right. Now, Olga, I know you wanted to talk about shoulders, in particular rotator cuff injuries.
I certainly do. I'd like to talk about shoulders, and then we might come and revisit some causes of bone pain in some kids. But at the moment, in my general practice, I'm seeing an enormous number of patients with shoulder injuries, mostly subacromial bursitis, occasional AC joint problems, and a large number of patients with rotator cuff injuries and tears. I'm sure there weren't that many people with rotator cuff tears when we were students. What's going on?
Well, I think it's the same scenario as we've just been talking about with the creaky joints, in that rotator cuff tears and impingement and rotator cuff disease is a continuum of disease, right? Starting off with a bit of inflammation through to thinning of the cuff, followed by a full thickness tear, followed by degeneration, and that occurs over the lifetime of the rotator cuff.
So the chronic inflammation will thin out the muscles.
The cuff itself goes through a degenerative process, just like our skin, just like everything else, and so. But in association with that, it is in a poor mechanical environment, i.e. it's got the humerus below and the acromion above. So if you're using the shoulder a lot, manual labourers, sportsmen, and have poor quality cuff, you're much more likely to have a cuff problem at an early stage.
Now, you describe it as a disease. Olga called it an injury.
Well, basically, it is a degenerative condition, and at some point along that pathway, an injury may occur. And when you're 20 years old, it's very hard to fall over and tear your rotator cuff. But when you're 55 and you have a degenerate cuff, and you are living a very active life and so on and so forth, and you have a small fall, you can create a tear, which then may be a partial tear, which creates inflammation and pain and symptoms of impingement, which we commonly see, right the way through to a full thickness tear. And it's just easier for that poor quality degenerate cuff to tear as we all get a little bit older.
And for my country patients who are tuning in, please do not throw sheep onto the backs of utes.
Exactly.
Which seems to be the easiest way to tear it in a hurry.
But excuse me, how are we going to get the sheep onto the back of the ute?
There are such things as hoists and ramps, Jerry. It's just as much easier to pick it up and give it a shove. So what clinical features are you looking for when you think that they've actually done a tear? Is there something particular?
Well, it's sometimes difficult to tell whether they've actually done a tear or whether they just have impingement or bursitis. But at the end of the day, what we're looking for is a painful arc. That would indicate that there is a rotator cuff pain, i.e. as they lift the arm has no pain when it's beside their arm, and as they lift it up, they feel the pain. So that's a painful arc, and it would indicate there's a problem with the rotator cuff. Whether there is actually a tear there or not, if once the patient has weakness, to actually get demonstrable weakness, I think there has to be a fairly sizable tear in the rotator cuff of a fairly long-standing nature.
What would ultimately determine if there was a tear? Something like an MRI or an ultrasound?
Yeah, I mean, ultimately, the ways, to either clinically, because it's very obvious that the patient is weak, but we use ultrasounds now, which are a guide rather than a definitive sort of printout is exactly what's wrong. An MRI scan is a little bit harder to get, but it's a much higher quality image of the rotator cuff, and will give us a lot more information.
So country areas, obviously we can access musculoskeletal ultrasound in some regional centres.
But not everywhere.
Exactly.
But not everywhere.
But the point about the ultrasound is it's a very, it depends very much on the operator who's actually looking at the rotator cuff and the skill level of that person. So the most skilled people can give you an ultrasound that's as accurate as an MRI scan, and the least skilled one is as accurate as a DICE.
In the absence of all of that high-tech machinery, which is basic, I guess, these days, but nonetheless not available everywhere, apart from this ARC test, are there other tests that a GP can do in his or her surgery to determine the extent of the damage or the nature of it?
Well, the GP is going to examine the patient with a range of movement, and the patient may have a reduced range of movement, especially in abduction. The patient may have a globally restricted range of movement, i.e. in every movement from external rotation to internal rotation, putting the arm up the back is restricted, and that would be much more likely to be a frozen shoulder. And these two things can very much coexist and confuse the picture. So ultimately, you're asking me if the GP can do a specific test to tell you that the patient has a rotator cuff tear.
Correct.
There is not a specific test. Everything is a weight of evidence. So what I do is I would take a history from the patient, look at the age of the patient, examine the patient, get my test together, and at the end of that, I'm likely to have a pretty accurate answer.
So John, what are our treatment options for a patient with a partial or a full thickness tear? Can you just leave it?
Well, I think, again, you want to look at that patient's, the needs, the demands, the age of that patient. Obviously, if a patient is lower demand, elderly, has a long-standing chronic full thickness, all we're doing is we're managing the patient's symptoms as best as possible. On the other end of the spectrum, if we have a 32-year-old with a full thickness rotator cuff tear that has occurred, particularly through a traumatic episode, that person needs surgery. So one person needs urgent surgery. At the other end of the spectrum, they need pain management, really, and functional management. So that in between, the judgments have to be made. So at the end of the day, whether a rotator cuff is repaired or not depends on the physiological state of the patient.
And the requirements of the patient to have that movement back.
So you can have a 65-year-old, a 68-year-old, a 70-year-old who's in excellent physiological condition, has a small cuff tear that will do extremely well with a subacromial decompression repair of a rotator cuff. But we have to make those decisions based on their physiological state. And equally, you can have a 48-year-old chronically ill, someone on steroids who smokes, who's not going to do very well at all with a rotator cuff repair.
Are my patients doing themselves any harm when they say, I've got to finish seeding and then we're shearing? And if they delay it for 3 to 6 months and throw more bloody sheep on the back of the ute?
Again, they are potentially doing themselves harm, depending on, if they reach the point where they have a small tear, they just ignore the pain, this thing becomes large, chronic, and not managed, it can reach the point where it is completely irreparable, and then they may find themselves in a position where they're approaching retirement and they have a degenerate arthritic shoulder, which could potentially have been avoided. But it's not just surgery, it's a combination of lifestyle change, education, rehabilitation.
Can these things fix themselves if you immobilise it and rest it? Can it fix itself?
Well, it depends what you mean by fix themselves. Certainly, the pain can be reduced. I mean, symptoms go away with certain types of tears, certainly partial thickness tears, bursitis. That can definitely be improved with getting rid of the activity that brought it on in the first place. With physiotherapy and a judicious use of occasional steroid injections. Yes, symptoms can reduce. I think once you have a full thickness tear, it doesn't repair itself. So I always tell the patients it's like a fingernail. Once the fingernail is torn, it doesn't heal, but you can remove it. Whereas once the rotator cuff has in fact torn, the only way to get that to fix is to actually cut back the atrophic edge and put the healthy cuff back onto the bone and fix it there. So no is the answer to that one.
Yeah.
Very
Is
good.
there anything sinister that can present as that sort of shoulder pain?
Yeah, absolutely. And I think, yes, any a form of infection, tumour, primary or secondary, is well known that people are treated for a long time with impingement and rotator cuff disease when in fact they've had a tumour there. But I think the symptoms are, slightly different, and really.
So yeah, what is it that rings alarm bells
Well,
for
what would
you?
ring alarm bells for me would be pain at rest. And a night pain, although night pain is also a feature of impingement and a cuff disease, but I think, and anyone who has any systemic symptoms associated with that as well. But I think really pain at rest and constant pain as opposed to pain that actually occurs on movement of the arm. Because really a cuff tear pain should occur when the cuff is being irritated, i.e. when the shoulder is being lifted up.
So, patient with pain at rest, like, would you X-ray every potential rotator cuff tear just to make sure there's nothing noxious?
I would categorically X-ray every patient that came in with a cuff tear. Far more, and I find that's the far. If I had the choice of an X-ray and ultrasound, it's always an X-ray because it will give you far more information than the ultrasound scan.
Good. Well, at least we've got those.
You'll also get some information back from the quality of the pain that the patient describes. Most musculoskeletal pain, you know that you give them some painkillers or non-steroidals, they're feeling much more comfortable.
Yeah.
But you get some of those patients who've got dreadful amount of pain, yet your investigations don't look that bad, but they're pacing the house, they're overdosing themselves on painkillers, nothing's touching the pain. That has to ring huge alarm bells. And you've got to remember that the C4 nerve root supplies over the shoulder, so even neck pathology can come in with dreadful shoulder pain.
Quick question before we take our next item. What do you two eminent, highly credentialed, highly skilled orthopaedic surgeons make of chiropractic treatment?
Oh, I did a thesis on this. This is a good one to ask. Chiropractic treatment is good for musculoskeletal, neck and back pain. The actual treatment they use is very similar to the treatments that manipulative physiotherapists or osteopaths or anything else use, and that's fine. My concern about the chiropractic treatment is when they start to talk about readjusting energy flows and altering blood flow to certain organs and treating generalised systemic diseases by spinal manipulation, because that involves a certain trust in magical thinking.
I didn't even
They're
realise
going to
they
fix your
treated systemic.
gallstones. Yeah, gallstones, babies with colic.
Oh, look, I've just pulled the pin on a hand grenade here. Let's leave it there. I think at this stage it's probably a good place to halt our discussion. And we're going to hear from the inaugural head of the podiatry program at UWA. That's Associate Professor Alan Bryant. We spoke to Dr. Bryant about the use of foot orthotic devices for the management of foot and lower limb dysfunction.
Alan, patients often come to the GP with foot pain or flat feet, and they want to know whether or not the podiatrist can help them with some orthotics or whether they should buy something off the shelf. What sort of conditions are most amenable to orthotics?
First, I have to say that flat feet aren't always symptomatic and they don't always need to be treated by a podiatrist or by the pharmacy. But certainly if there is a condition that's amenable to orthotic therapy, to altering the function of the foot, then a referral to a podiatrist would be indicated.
Now, orthotics seem to be a bit of a contentious issue, and a large number of my patients moan to me that their orthotics are killing their feet and that the podiatrist's given them something rigid made of fiberglass and it doesn't help. Where are they most useful, and what's the principle that you actually prescribe on?
I agree that sometimes orthotics can be too hard, and perhaps rigid orthotics are possibly overprescribed to a certain degree. But there are a wide range of conditions that orthotics are applicable for. The foot, after all, is a structural part of the body, and it is susceptible to a whole host of musculoskeletal injuries of one sort or another. And these can be acute injuries, and these can be overuse, chronic type injuries. They can be related to the structure of the individual, not just of their foot, but of more proximal structures as well. So there's a whole host of conditions where orthoses are useful. I guess one of the most common conditions that orthoses are prescribed for is for heel pain. Now, heel pain is not a single entity, of course, as you know, and it consists of a number of different conditions, the most common of which is plantar fasciitis. And certainly where plantar fasciitis is associated with excessive pronation of the foot, foot orthoses are certainly indicated. In the normal foot, there's a normal convex curvature of the medial longitudinal arch. Another sign of a normal foot, and you can see this on an X-ray, on a weight-bearing X-ray, is if you bisect the head and neck of the talus and project that bisection anteriorly, it will actually bisect the head of the first metatarsal. And that indicates that this section of the foot is normally aligned. The heel of a normal foot will be slightly inclined, or the calcaneus will be slightly inclined, as opposed to an excessively flattened foot. If this was an X-ray, if you can imagine a weight-bearing X-ray, if you were to bisect the head and neck of the talus here, the bisection would actually exit about here rather than through the first metatarsal. So that indicates that the talus is plantar flexed. With subtalar joint pronation, what happens is the talus plantar flexes and adducts. The calcaneus plantar flexes. So you get an overall flattening of the rear part of the foot, which in turn gives a flattening of the midsection of the foot.
And is that what's causing the pain? Is it just ligamentous stretching, or is it actually arthritis starting? What's happening?
It can be either. With plantar fasciitis, it's thought to be just micro tears in the plantar fascia where they insert into the medial tubercle of the calcaneus. You can imagine, well, it's not hard to imagine that in this type of foot, long-standing excessive pronation of the foot, where the joints are not aligned as they should be, that you do get excessive wear and tear of the dorsal aspects of these tarsal joints. And it's quite common to have an elderly patient in their fifth or sixth decade present with midfoot pain. And if you examine them clinically, they'll have a dorsal lump over the mid part of their foot. And if you look at a weight-bearing X-ray, you'll see that there's some osteophytic growths on the navicular and talus and on the metatarsals. And the first line of treatment should be an orthotic device to support the foot, to minimise the joint motion, which is, of course, the mainstay of all conservative therapy for arthritis. Yeah. And that's the lesser of those three evils: orthoses, injections, or surgery. Injections can be tried, and they will often give temporary relief of the pain, but they don't actually, of course, treat the cause of the condition.
There's a lot of orthotics available over the counter, and then there are the things that the podiatrist prescribes. When are the over-the-counter things appropriate?
Some people, it has to be said, simply cannot afford custom-made orthoses, and in which situation over-the-counter orthoses are a good substitute.
So what should we get them to look for in an over-the-counter one? Do you have any examples?
This type of device is a fairly stock standard orthotic, and this would be useful for someone with medial arch strain or plantar fasciitis, and even for a younger, more athletic person who's perhaps suffering from tendonitis or shin soreness or one of these conditions. With a functional foot orthoses, most of the support is here underneath the medial proximal area of the foot rather than in the midfoot. It's really a common misconception that is filtered down to the over-the-counter orthotic industry, whereby you need to have a high medial arch support. You really don't. Most of the support should be in this area. to get effective control. If you leave it to here, you're really in the mid-stance phase of gait, and in many ways it's too late to try and support the foot. I think that's one of the reasons that people sometimes find orthoses uncomfortable, because they're not perhaps designed as well as they should be. This type of device, by comparison, is much softer and is much more applicable to an elderly patient or a diabetic patient who needs some gentle support, and with the emphasis on cushioning of the forefoot and so on.
Alan, if a person is wearing a good quality sports shoe, do they still need an orthotic?
It depends. It depends on the individual. And certainly the better quality sports shoes that you can buy do offer very good support. But having said that, it does not follow that if you have a foot problem that you can get by with just a good quality jogging shoe. And foot orthoses have a role, they have a place in treating musculoskeletal injuries of the foot and indeed the lower limb. But they're often required to be used in conjunction with other therapies like anti-inflammatories or physical therapy or whatever else is necessary.
And if country doctors require some advice from a podiatrist, are they able to get advice through the School of Podiatry?
We're certainly happy to answer any questions or give advice to anyone who wants to phone in and ask for some advice and some help. We run a teaching clinic here for our 4-year undergraduate program in paediatric medicine, and we'd be more than happy to accept referrals of your problem patients if that's required.
And our thanks to Professor Alan Bryant, the inaugural head of the podiatry program at UWA. Now, Colin, you do some work with kids at PMH. What about the use of orthotic for kids with flat feet?
A lot of parents go and see the GP worried about their kids' flat feet. And although the GPs tell them all the right information, they still, for some reason, need to come and see us so we can tell them that the GP was exactly right. But just to reinforce the message, all kids have flat feet at birth, the same as they all have bow legs. But if you look at a baby's feet, they're all flat. And they develop an arch over the first 10 years, but when they stand up and they're all loose kids with ligamentous laxity, their feet are flat. There's been some nice studies done where they've looked at the orthotic use in kids, and they followed these kids up for 3 years and divided them into 4 groups. One group they did nothing on, one group got special orthopaedic shoes, one group got a heel cup, and one group got custom moulded inserts that were fitted by a podiatrist. They monitored them to make sure they used them, and at the end of 3 years they looked at the kids' feet again. Radiologically and clinically, they all got better. So in other words, putting orthotics in the shoes didn't change the shape of the feet. Now, for painless flat feet, orthotics in kids are useless. Painful flat feet is a different story altogether, and you've got to investigate them. But for the kids who are just flat, leave them alone. It's not a disease.
Well, if I want to get into the police force or I want to get into the army, I can't if I've got flat feet. So can we fix flat feet?
The American podiatric surgeons operate on flat feet, and it's wonderful stuff. They earn a lot of money doing it, but it's completely useless. You don't need to operate on flat feet because it's an urban myth that they're bad. Herb Elliott couldn't get into the army because he had flat feet, even though he told them they didn't hurt and he was a very fast runner. This myth has been propagated throughout medicine that flat feet is some sort of disease.
So perhaps it's the armed forces who need to readjust their thinking about flat feet, and the police forces.
I'll leave that one to you.
Well, we just put the question out there. Now, do you have a pin on another hand grenade?
Well, there are lots of problems that come to us with children. Asymmetrical leg lengths and children who walk wonky or in toe or out toe. And I often just reassure the parents that this is a normal part of their growth phase and it will straighten up. And I have told them to go and watch Andre Agassi play tennis because he's got a tremendous in toe.
Is this what they call pigeon toes?
Yeah. But Colin, are there any kind of alarm bells or signals that you might actually say that really isn't right?
Again, going back to the kids. Kids are all born bow-legged, And by the time they're about 2, they're straight. By the time they're about 3.5, most kids are knock-kneed.
Yeah.
And then by the time they get to primary school, most of them have achieved a fairly adult alignment pattern. But the same way, kids start to walk when they're about 12 months, but they walk in an abnormal pattern. And it takes them until they're about 4 to 5 before they have a mature walking pattern. So for the first couple of years of life, they are walking and falling over. So for a 2 or 3-year-old to go running up the corridor, trip on their feet and face plant is normal if they're going to start running. They are not tripping over their feet because they're in-toeing a bit. Most of the kids who in-toe early, as they grow, will tend to straighten up. And there is no greater stimulus for them to straighten up than when they want members of the opposite sex to look at them in high school. They straighten up very quickly. The ones who are profoundly out-toe don't in fact improve with growth, and some of those kids will come to surgery, but it's pretty drastic surgery, so they have to be pretty severely affected.
But at what age would you look to intervene? At what age would you say there is a problem that needs to be sorted by surgery?
For doing surgery to rotate limbs, you're talking about late primary school, early secondary school.
So 11, 12, that kind of age.
Now, they're also the kids that seem to start turning up with growing pains, and they're often really severe. And I've got no idea and no constant method for treating them. Is there a really hot tip for treating growing pain?
Mainly reassurance. They've done the research, surprisingly, on sheep, where they put transducers across the growth plates of immature sheep. And they looked at how much the growth plate moved on 5-minute intervals throughout a 24-hour period. And they found that while the sheep were standing up, no movement occurred in the growth plate. It was only when they lay down and became recumbent and the gravitational pressure was off the growth plate that the growth plate could in fact spring apart, which explains why kids who are going through rapid growth phases go to bed at night, the growth plate starts screaming apart, stretching all the sensitive periosteum, so 3 or 4 hours later, the kid's awake, screaming in pain around their knees usually, because that's where the fastest growth's happening. Mum's up, rubbing the legs, pacing around the house, kid has a drink of milk and after half an hour goes back to sleep, wakes up in the morning like nothing's wrong.
Except he's 2 inches taller.
Exactly. If you can predict when it's going to happen, and sometimes it happens more when they're eating more physically active, then sometimes pre-treating them before they go to bed with some anti-inflammatories can help.
So a little dose of Nurofen on bedtime?
Yeah. Do that for a month and then stop it again and see how they go. But essentially, it's a phase they have to go through when they're growing that rapidly.
I thought that was a myth, growing pains, or it's maybe that I never grew past 5'7".
It's a real thing, but it's normally in the middle of the night.
Colin, the other paediatric thing that really causes a lot of angst for GPs is kids with clicky hips. And I know there's an awful lot of ultrasound now available in hospitals which deliver babies, but how unstable is unstable?
The names change from the American lawyers. We all used to refer to it as congenital dislocation of the hip, CDH.
Yep.
Sounded sensible. The American lawyers got hold of the term and said congenital by definition means present at birth. So every single doctor that's seen that child since the moment of birth has missed the diagnosis if we're going to call it CDH. Now the research has shown that some of these hips are in fact in joint when the kids are born and sublux or dislocate later on. So for that, and to get away from the lawyers' slam dunk ability to sue us, it's now been referred to as developmental dysplasia of the hip. Again, the 4 main factors to make you worry about it in a newborn, apart from your physical examination, is the female babies are more likely to get it because they've got the same receptors for the hormones that have made mum's ligaments all relax, go straight across the placenta and relax the female babies as well. Firstborn babies are more likely to have it because they're in a tighter muscular bag. The uterus is being stretched up for the first time. Second kid goes into a pre-stretched bag. If there's a family history of it, or if the kid's in a funny position, especially a breech, they get pressure on the hips, forcing them out of joint. But if you are concerned about the hip, then my suggestion is get the kid to a centre where it can get an ultrasound done.
And that's a definitive enough test?
CYA, cover your ass. It's a definitive enough test to have the GP be seen to have done everything they could possibly do.
And this is soon after birth, Colin?
If you're worried about the hips, then get the ultrasound done in the first couple of weeks.
Right.
You don't have to get it done in the first week, and in fact we probably encourage you not to get it done during the first week because so many of these hips are loose during the first week. But after the first 7 to 10 days, any of the abnormal laxity just through the hormonal influences of delivery should
So
have disappeared.
it's usually when the mum brings the baby in for the 6 to 8 week checkered pre-immunisation check.
Was this the one where they used to suggest the tight nappies for the kids for a period of time? Was that
It's
the
a
one?
good
Double
way to make
nappies.
Huggies very, very rich.
Is that right?
They don't work for CDH. If you've got an unstable hip, they need to go into a decent brace, not double nappies.
I had a friend who, shortly after, about halfway through her pregnancy, she was told that her child was going to have a club foot, but that this was going to be surgically sorted at birth. How difficult is it?
20 years ago, these kids with club feet used to be left until they were about 9 months old. Then we used to do this ghastly operation to cut through everything and correct the foot, and it was awful.
Yeah.
We now treat it in a much more humane way insofar as soon as the kids are born, we start stretching the foot with a series of plasters that are changed each week over about 6 or 8 weeks. And at about the 6 or 8 week mark, 90% of these kids need a tiny operation where we just put a scalpel blade through the skin and cut the Achilles tendon completely, which allows the foot to pop up. The Achilles tendon reconstitutes itself beautifully, and these kids end up with a flexible, plantar grade foot that they can run around and do without the major destructive surgery we used to do.
That's fabulous. How many incidents like that do you see these days?
The incidence of club feet that needs treatment is about 1 in 1,000 live births.
Right.
Unfortunately, the technique for plastering them is a skill that isn't in the rural centres, so unfortunately these kids have to come up and down from Perth
Every week.
each week or 2 weeks. You know, thank the Lord for PATS, thank the government for PATS scheme.
Yeah. Colin, you're talking about plaster, and my last paediatric specific question is the children who come into general practice surgeries, as they do, with various broken items, and in country centres, as often as not, the only thing we've got is plaster of Paris, which is brittle and heavy. What sort of alternatives could there be?
The amount of difference between the plaster of Paris casts
Yep.
and the modern synthetic casts is not that great. We've looked at them at PMH, and at PMH the vast majority of casts we put on are still out of plaster of Paris because it's the best moulding plaster. So although they can't swim in it, it's still a good way to go. We did try the waterproof cast at one stage at PMH for the long arm and long leg casts, but although they're waterproof and they need to get destroyed by the water, there is an onus on the parent and the patient to dry them out properly afterwards, which means you've got to hold them up, drain all the water out, and then for 20 minutes sit there with a hairdryer drying them. And no one would do that. So we saw a very high rate of
Macerated
ulcers.
skin under it,
Yeah, macerated skin at all their joints. So we've gone away from them and are still just using plaster. There are some new things on the market now, some waterproof sleeves that can go over plasters that people can still swim with and shower with. They're a bit pricey, but they work very, very well.
So that's what the rubbish bag and the lacky bands for.
Cling-
The lacky bags don't work.
Cling wrap, wouldn't that work just as well? Cling wrap and
As long
lacky
as you
bands?
seal
No.
the ends.
No?
No.
Okay.
You really do need to seal it. Now, in general practice, we see a lot of adult patients who come in and they complain about hip pain or ankle pain. And as often as not, they don't have actual joint pathology. Could you comment on some of those other conditions that might affect our patients?
I'll hop in on one on the ankle.
Yeah, well, I mean, patients who come in with hip pain, obviously, we first of all have to establish what they actually mean by hip pain, because you know what they mean by a hip might not be what the orthopaedic surgeon or the general practitioner thinks of what the hip is. So it means the first thing I do is just ask them to point to exactly where their pain is. And it may be groin pain, buttock pain, leg pain, knee pain, all sorts of different areas. And I think that's the most important thing, to kind of work out exactly what they're talking about. And then essentially what we need to do is try and work out exactly what the diagnosis is there, because they're just giving a vague symptom. And you know, hip pain, for example, could be coming from the hip, it could be coming from the back, it could be coming you know, from a variety of possibly even intrapelvic structures. So And then, so basically we need to go through that regime that we normally go through, the history examination, and then test to try and work out what's going on. And I guess what you're suggesting is that they come with vague symptoms that aren't all that specific. And this is why we gather the weight of evidence that as we go through our whole process to try and actually come up with a diagnosis, then we may know how to treat them.
Well, quite a lot of them come in with lateral hip pain, and they say, I can't sleep on my side, doctor. And I guess we've always labelled that vaguely trochanteric bursitis. Often responds well to injections, but what's actually going on there?
Well, I mean, trochanteric bursitis may be a true inflammation of the trochanteric bursa, which is a bursa that lies over the greater trochanter beneath the iliotibial band. But again, that it's inflamed secondary to something, which may be a variety of things, from where the patient, the shape of the patient, the tightness of the iliotibial band. They may have a chronic, they just have developed a chronic inflammation there, or they may have pain secondarily from somewhere else. So they may have pain from torn or partial tearing of the short rotators of the hip. And again, we just need to do some tests to try and work out exactly what the source of that pain is, and then treat it appropriately.
Okay, so how would you examine that to elucidate what it's coming from?
Well, again, I'll find out exactly where their pain is, and if they point to the greater trochanter and have a point of tenderness, I'm thinking more along the lines of a trochanteric bursitis rather than some other generalised pain from somewhere else. And then we're going down the line of examining the hip and examining the gait and the way they walk, and then trying to establish as to why has this occurred, and then maybe the judicious use of an ultrasound scan to try and give you some sort of weight of evidence as to whether there is some sort of inflammatory process going on there, whether there is fluid there, and whether a local anaesthetic injection will take away the pain from there, which would indicate that is the source of the pain as opposed to pain from elsewhere.
Now, we've often told them to do iliotibial band stretches. Can you describe what sort of exercises you would tell the patients to do?
Well, I would send them to a physiotherapist, but Colin might be able to advise us a little bit better on that one.
Certainly you want to try and do some stretches if you believe that the iliotibial band is tight. And if you're going to do it, then the easiest one to teach people and the best one to do is to just put the affected foot behind the other foot, keep both knees straight and bend over. Gives you a wonderful, wonderful stretch. But on John's point, a lot of the lateral hip pain, if they have an ultrasound guided injection of local anaesthetic and steroids, so you know from the ultrasound it's in the right spot, they don't respond to it and they've had multiple attempts, you've got to start thinking whether it's something else. And certainly some of the imaging studies that we do, mainly an MRI scan nowadays to look at the soft tissues, is showing us that these people have chronic gluteal tendon tears, a bit like the rotator cuff tears in the shoulder.
Yeah.
So all the steroid in the world isn't going to help this degenerate, torn, painful tendon.
So what will help it?
Patient education, removing the stresses, modifying the lifestyle. If people are severely affected, possibly an operation, but it's not a good operation with a low success rate of maybe 50%.
Yeah. And Colin, you were also talking about ankles. And
Ankles?
I see people post-sprain particularly, and they've got that nice big bubble of fluid that seems to sit there for years. But what's going on?
Often when you talk to them and you ask them about the injury, they've had a massive plantar flexion inversion injury.
Yep.
Egg appears within minutes, indicating that they've completely torn their lateral ligament and it's bled. That's why they get that nice golf ball hematoma. And then it settles down, but they don't go through the rehab. So if you ask them very carefully about their ankle, they'll say they haven't sprained it again, but 2 or 3 times a day when they're on uneven surfaces, they'll feel their ankle go halfway over and come back. So they have in fact got a recurrent injury. That's why it never settles down, because they've never rehabbed their muscles around their ankle. If you look at them, the simplest test to do is to ask them to do a single leg balance on their unaffected leg and look at how fine their motion is, how good their balance is, and whether they need to put their foot down, and then test it again on the injured ankle and see what their time's like. Most people have appalling balance on their injured ankle because they haven't gone through to re-educate their proprioception around the ankle. So I tell them to stand on one leg, it's a simple exercise, during the ads in the TV break. They should be able to get through 3 minutes standing on one foot without putting their other foot down.
In general terms, do we suffer from a lack of properly developed muscles in our ankles anyway because of our sedentary lifestyle, perhaps?
Well, it's a use it or lose it phenomena. When you're at school, you're doing sport, you walk home, you're standing on the fences as you go down the road, you're using your balance all the time. Then we get a job, we get busy, we drive cars, we stop all our sport, we don't challenge our ability to balance, and hence our ability to balance gets worse.
So as we continue to evolve, one day we will have no muscles in our ankles.
We won't walk.
That's right.
That's it. And just finally, speaking about ankles, could you talk about Achilles tendon injuries, which we do see occasionally, mostly in netballers again?
Achilles tendon
Well,
injuries.
I mean, Achilles tendon injuries. Again, it is a tendon. It's full of collagen, and it goes through it goes through a degenerative process from 0 to 100. And the people who are most prone to it. Achilles tendon injuries are those who are a little bit older, i.e. the quality of the tendon is not so good, but they're still playing explosive sport, maybe netballers or squash players, or and perhaps smokers, and this sort of type of people who are still doing explosive sport and they get an acute tendon rupture. And then we then have to try and work out whether we should be fixing these or not.
So from the GP's point of view, when the patient comes in and they're going, or, how would we assess that to work out whether or not their Achilles tendon's completely gone?
Well, the first thing you need, take a history, find it, look at the people who are at risk, as I say, mid-40s, playing sport, explosive activity, and they felt the thing go behind their leg.
Or return to sport. Haven't done it for a couple of years, just gone back to play squash. Bang.
So there's a test called the Simmons test, where you kneel the patient on the side of the bed, and you give the
calf
a squeeze. And really, if there is no continuity between the calf, the Achilles tendon, and the ankle, there should be no movement of the ankle. And sometimes you can actually feel a palpable defect, in the Achilles tendon. But sometimes in the acute phase, it's painful and swollen. So it's less easy to do.
So for a GP seeing a patient with this, obviously this, a younger person is going to require a fairly rapid repair. How would we treat that initially? Just rest ice?
Well, they don't
compress?
have to have a rapid repair. I think there is a tendency in a younger, fitter person to repair it because it has a lower rate of re-rupture. But certainly in an older person, you might not do that because there's a higher rate of wound breakdown. So we certainly in the public hospitals where we see a lot of these sort of cases, we'll be treating them with plaster. And I think from a GP's point of view, I think if any doubt, you can just put the patient in a plaster with the foot in equinus. The idea being to just oppose the ends of those tendons, and then make a referral as to whether to see someone as to whether they think repair is appropriate. And I think if that's the case, it does need to be relatively soon, because it's certainly nicer to be repairing these in a week or so rather than at 5 or 6 weeks.
Well, Olga,
one trap. Got to mention one trap there for the GPs. These patients that come in, they often say that they felt someone hit them in the back of the calf, even though no one was behind them, because that's when it ruptures, it's an explosion that sometimes people can hear from feet away. A lot of these people will come and see them, they'll have swelling, you can't feel a gap because they're so swollen, and the GPs will ask them if they can plantar flex their ankle. And all the patients with complete Achilles tendon ruptures can still actively plantar flex their ankle. It's because all the other muscles that go down behind the malleoli, so all the long flexors of your toes, can also plantar flex your ankle. So don't just ask them if they can plantar flex their ankle. It doesn't mean their Achilles tendon's intact. You've got to do the Simmons test or get a decent ultrasound.
well, I think the consensus from your presence on the programme tonight, gentlemen, is that getting older is definitely not good for you in one circumstance or another.
Better than the alternative, Jerry.
Of just dying young and good
That's
looking.
it,
Yes.
yeah.
I think you're right too. Final word from you, Colin?
Just remember that you've never been as old as you are today, and tomorrow you're going to be older.
You think that's a comforting thought?
No.
Colin, thanks for being on the program tonight.
Thank you.
Jonathan, you too.
Thank you very much.
Dr. Jonathon Spencer and Dr. Colin Whitewood and Dr. Olga Ward, thanks for your contributions.
Thanks, Jerry.
We will be back again in a month. In the meantime, don't forget that if you'd like to review this program or any previous program, you can watch them online or download them as a video or audio podcast via the Rural Health West website at www.ruralhealthwest.com.au. As I said, we're back again in a month, on the 6th of April, in fact, with an update on viral infections, including H1N1. So if you have any questions you'd like answered on that topic, please get your evaluation forms back to us as soon as possible. Thank you for taking the time to join us. And by the way, do also, while you're on our website, check out our upcoming conference late in March. From all of us here, good night and thanks for joining us.